Welcome everyone. And today we get to have highlight some of our nurses in our region and the work that they do or have done, and get to learn some opportunities and new ways to support our students. So we'll hear from Kathy first about our state and regional updates, and then we'll get to hear from Liz Prey from the Moses Lake School District and about some health emergency drills that she instigated in her district. I don't know if you remember, I believe back in February, we had heard from Mike Dingle, the student safety coordinator here at the NCESD. He talked about some of those health drills, or at least touched on it. And so now we get to hear a little more about it. And then at 10, we'll hear from Dr. Wallace on the regional health updates. And then 10:30, we get to hear from Amanda Peasley from Pinnacles Prep about some recent pertussis cases. So as always, meeting objectives to become acquainted with resources that we can utilize to support and maintain our students, the safety and health of our students. And then the goals would be to identify at least 2 areas of your work with student safety or communicable diseases that you can incorporate into your practice. And then I have the framework up here just to be mindful of where this fits into what we do for students every day, and care coordination and leadership are ones that we always participate in. So as a reminder, this meeting is recorded, so please keep your microphone on mute. If you have a question or comment, please feel free to raise your hand. You can always put a comment in the chat. Sheila and I will be monitoring that so we can make sure that your questions or comments get read out. Also, a reminder that this is we do have clock hours offered for this, and that you can attend the live meeting or watch the recording. We would need you to fill out the attendance survey and complete the PD enroller survey, and then at the end you'd pay for your clock hours. So, that's for the end. So I'm going to stop sharing and turn the time over to Kathy.
Okay, thank you so much, Lena. Good morning, everybody. It's so nice to see you all on the line this morning. I'm going to go through some state and regional updates, and I'm going to apologize in advance. I have to log out after I'm done for another meeting, and then I'm going to be logging back in kind of quietly in the background because I'm really anxious to hear as much of people's presentations this morning as I can. So I'm going to go ahead and share my screen. We're going to go through some updates. So can everybody see and hear me okay? Thumbs up. All right, very good. Okay, so let's go through some quick things. First of all, I want to welcome 2 new school nurses. I'm not sure if they're on the line, but I see Amanda smiling because one of these nurses, Emily Lumpkins, is actually working with Amanda at Pinnacles Prep. And I had the chance to meet Emily yesterday, and she's just absolutely wonderful, and looking forward to working with her there. So Emily has joined the team, and so has Tanya Reynolds. And I don't know if Tanya's on either, but Tanya is joining the Oroville School District and is planning to work with Olivia as Olivia transitions out and gets ready for the end of the year. Tanya will be there taking on the role up at the Oroville School District. So welcome both Emily and Tanya. We're really happy to have you on board with us. Okay, first thing I want to start out with is just an update about manuals. This is the time of year when OSPI and School Nurse Corps and Department of Health and lots of stakeholders get together and look at the Washington State health-related manuals. So these are things like diabetes and infectious disease management. We have several of them, and they're all kind of in a different time frames because they get updated, at different times. And this one, our diabetes manual, is probably one of our more recent manuals. It actually was last updated in 2018, but already has needed to have some revisions done. And so a group was formed to look at this manual and to make some revisions and some additions to it. So before you print this, don't print it yet, but we do encourage you to, certainly recycle your older version and move on to this new version of the manual. So some of the things they added to this, cultural considerations have been expanded, diabetes descriptions have been expanded. We get new medications, and that's one of the reasons why these manuals get updated is largely, a lot of times it's because medications and treatments advance, things are sunsetted, new things are brought on. And so it's really important that because these are our guides for our school nurse practice, we want to make sure that everything in there is actually current. So you have resources to go to if there's a new piece of equipment or there's new monitoring or new medications. We want to make sure that your resources are up to date. So this particular one has multiple revisions to it. If you don't have the opportunity to open it up and read it from cover to cover, which certainly can be challenging, there is at the beginning of the manual a quick table of the changes that were made to the previous version. You also have lots of links to forms on here. Many of the forms in the manual are actually housed on the Google Drive for you in the diabetes folder. And you can find that under your toolkits. Look under toolkits and then diabetes, and then you'll be able to find where you have a lot of your forms downloaded for you already in there. And then there's a link here to this manual on the drive. So then the reason I said don't print yet, or if you have already printed, it doesn't take very long when one of these manuals comes out for someone to say, oh, did you look at this on page such and such? And here the manual was printed and distributed and links were put out. And sure enough, a school nurse who was reviewing this said, hey, wait a minute, what about this table on pages 66 and 67? It does not look complete. Did something change? And really, no, nothing changed, but something on the table was omitted. And so there are some revisions being made to it. And in fact, we're due to come out yesterday. So I just wanted to make sure and show them to you. And largely, this was really just an omission of authorized personnel who could perform tasks around the student with related to their diabetes management. And some of the UAP authorized tasks didn't get listed on here. And so this is going to be revised, and the newest version will be posted. And as soon as I hear that it's up and available, I'll let you know. So far, that's the only thing that we've gotten feedback out about this particular version of the manual. I do get a lot of questions about diabetes, and I'm sure Lane is getting a lot as well. It is one of probably the most challenging diagnoses as you have new diabetic students coming into the school to look at all of their various needs. And so just as a kind of a reminder, I wanted to let you know that we have checklists available and encourage the use of these kinds of tools if managing a diabetic student is new to your practice, or you just have not done it for quite a while, then we just really encourage you to pull out a little checklist type tool and really help you organize all of the things, the steps that need to be considered in the care of that student. So this is just an example. This particular one is from Seattle Public Schools. We also keep one, and this is in the Google Drive. We have another one we keep in the Google Drive. These are really just tools that people can use to help reference the care for the student. Now, we're getting towards, and please ignore the fact that this slide has all this text all over it. This isn't intended for you to read it. It's really just because these slides are going to be available to you, and I want to make sure that you have the information where you can use it as a reference. But it's certainly not anything you have to read right now. It is really about the fact that we're approaching the end of the school year. We're prepping for next school year, and in preparation for next year, PDA training needs to occur. So if you're planning to have, you already know that you have PDAs for next school year to help with care of students with diabetes, then we just wanted to make sure you were aware of the process for if you're interested in having Confluence Health do your PDA training, then we have a process in place to do that. And what we encourage you to do is just connect with Sheila. Sheila connects with the administrative assistant at Confluence Health, and between the two of them, they determine availability of the certified diabetic educators to provide the program, and will provide some specific dates and times where school districts can sign up and select their dates and times that work for them and that work for the diabetic educators as well. The courses that Confluence Health does are almost exclusively done at Confluence Health conference rooms in Wenatchee. They do on occasion do one remotely if there's a need for that, but and we'll talk about those virtual kinds of courses on the next slide. But just in general, each course is about 2 hours in length and covers some fairly basic elements of providing diabetes care. It is based on an individual student's plan. So students' plans have to be in place before PDA training is done, because that's what the training is based on. So the certified diabetic educator needs to get a copy of the student's plan of care for the school year. So a lot of this training is done towards the end of August, when the unlicensed assistive personnel are coming back to work and you've identified who those PDAs are going to be. At that point, the plans need to go to Confluence Health. We encourage you to assign some of the American Diabetes Association modules to your PDAs and have them work through those modules prior to going to their PDA course. And the reason for that is, particularly when you have new PDAs in the role, you can imagine how difficult it might be for an unlicensed person without former healthcare experience or PDA experience to understand the ins and outs of caring for a student with type 1 diabetes. So these modules are quick. They're quick, good video-based modules that can help provide some of that more of the baseline information about, what is diabetes and what is type 1 diabetes, because often in the PDA courses, there isn't the time for those more baseline types of information. And so having these modules done in advance really helps PDAs go into the course with a good base of information, and then to be prepared with questions that are specific to how are they going to manage this particular student during the course of the school day. So those dates and times are going to be posted. Sheila's working with Confluence Health already on identifying what those are. Now, this is not a a mandate. You don't have to use Confluence Health. In fact, if the students are actually being seen, for example, by Providence in Spokane, then Providence would be a great in a great position to provide PDA training. Theirs is going to be virtual. They won't be coming to your school. So we'll talk about virtual training here in a minute. The other option is if your students are seen by Seattle Children's, that's certainly an option, but they don't do a remote program solely remote. So in that case, it is more challenging because the student and the parent would, or whoever is going to be serving as the PDA, would have to do some of their training in Seattle, at Seattle Children's. And Seattle Children's has not been able to provide the staffing that we would need to have them come over to our area and actually conduct the PDA training here. So, so theirs is really more virtual, and some Seattle work as well. So there's different options for doing the PDA training, and certainly school nurses could perform PDA training. And the caution I would share about that is you want to be very sure of your diabetic management skills. If you're going to be doing the PDA training, per the RCWs, it needs to be done by somebody with a lot of expertise in diabetic care for the pediatric patient. So if you fall into that category and you feel comfortable with your PDA training, as some school nurses do, then certainly that is an option as well. But we really encourage people to look out for these certified diabetic educators and to use them for that program. Now for virtual training, if you're going to do virtual training, sometimes Confluence Health could offer virtual training. Providence has a form of virtual training that they do as well. In this case, someone needs to do the hands-on skill verification and practice with the PDAs. And so if you're going to be doing virtual training, just make sure that you're attending the training and you're there in the room, and that so you know what people are learning about, and you have your equipment, and then you're able to go through practice scenarios and skills verifications with the staff. So this means you're going to need to have your checklists ready, because you're going to need to sign off on the skills that the person completes while they're with you. And then those skills checklists, in the case of Confluence Health, for example, you would need to send those checklists over to Confluence Health. And then at that point, once that is done, then Confluence Health would send you a certificate of completion. So I know sometimes people have told me that they never got their certificates for their PDAs. When we're looking for PDA documentation in the schools, sometimes people are reporting they did not get them from Confluence Health. And largely it's often because Confluence Health did not receive the checklist to indicate that someone had checked off the PDA skills. So do make sure that that happens, and then they will get you your certificates for those employee files. When it comes to other documentation for PDAs, that would be up to the district to complete. That's not something that Confluence Health or Providence or Seattle Children's would do. So you should have your own PDA letters of agreement, for example, your own parent release forms for your PDAs. Those are things that are up to the school to have, and that would be required for those students' files. And this is just an example of the ADA module checklist. So again, this is in the Google Drive. You can access it there. And then these are all just hyperlinks to go to the videos. We do pre-select some of them, because certainly if the student has type 1 diabetes, we want them to complete the basic courses around diabetes management. But there's probably about 12 or 14 of these videos altogether. This is actually a 2-page document. And so at that point, once these ones that are assigned, the pre-checked ones are done, then the school nurse could assign the other ones. Again, based on the student's plan of care, you could select, well, which videos would it be appropriate for this PDA to be viewing. And these could be watched by other people as well. They're short, you can see they're not really long videos. But if you have unlicensed assistive personnel who are not working as a PDA, but who are going to be responsible for some of the monitoring going on around students with diabetes, these are really very good courses. They are pretty recent productions. They have intermittent testing questions built into them. And I think people get a good experience and a good baseline of information from them. So those are readily available to you.
Kathy, there's a question and a couple of comments in the chat. Can I read them out to you regarding the diabetes? So we have a question regarding the PDA. I see it says that it will bill the district. How much is this? And my diabetics doctor doctor's office did it for free, the PDA
Oh,
training.
fantastic.
And then do you have to have a PDA?
Oh, okay, well, let's kind of go through these one by one. So
Okay.
first of all, if your doctor's office or the doctor's office nurse will do your PDA training, that is superb, because they are going to know that student inside and out. So if they're willing to do your PDA training for you, I think that's fantastic. I didn't include it as because it often is not done, but if your doctor's office will do it, that is like the first place I would probably try to go. What we have found is frequently they do not, and so these other options are available to you if you don't have that, so this is just an option for Confluence Health or Providence or Seattle Children's to offer the program if it's not available to you in that other method. Now,
Okay.
cost-wise, that varies. It varies by who is going to be doing your course. So oftentimes there is no charge if it's your provider's office doing the course for you on behalf of their patient. They probably aren't going to be charging your district anything. But if it is, and Providence, if it is this, if the student's being seen by Providence and it's their patient, they probably will not have a charge for that either. But if you're using Confluence Health, then the student as a patient may not be a Confluence Health patient. They may be being seen for diabetes by another specialist. And so in that case, Confluence Health does make it available, but they do charge for it. Now, last year, the charge for a 2-hour course, most of these courses last about 2 hours. If you're going to be doing both your didactic and your skills, it's going to be about a 2-hour course. And the cost for the course last year was $300. And that is billed directly to the school, and it's up to the school. If the school chooses to use that service, then they would be responsible for that payment. They will do shorter classes, but again, I wouldn't recommend that you try to reduce the time frame for your courses just based on cost. If you're having some concerns about the cost of a PDA training course and you need the course, then do get in touch with us so we could see what kind of help we could provide for that. Now, the other question was, do you need a PDA? Do you have to have a PDA? A student doesn't necessarily have to have a PDA. The PDA is really there as the parent's extension. So this is really up to the parent. Sheila, I see you have your hand up. Did you have a question?
Well, I could have waited, but I'm working on the calendar right now, like you said, and we do have openings. She's still working on them, but early August. So,
Okay, all right. So we'll get those out to people so then
okay,
that's so they can know what those are.
okay,
So a PDA is an extension of the parent. So the PDA is a parent designated adult. The reason that we have PDAs is because there are tasks associated with diabetes management that cannot be performed by an unlicensed assisted person in the school district. A unlicensed person is not able to pierce a student's skin, for example. So an unlicensed person could not give the student an insulin injection if they needed it. You cannot delegate piercing of skin to unlicensed staff. So you could not direct another employee at the district to administer insulin, and you could not also direct them to administer injectable glucagon to a student if that's what their order was for. So in those cases, if those are what your student needs, if they need someone to administer potentially insulin to them, or if they need someone to administer glucagon to them and those routes are injectable, then the student would need to have a parent designated adult who would be able to perform those tasks in the nurse's absence. Because if you're only in the school part-time and the student is there 5 days a week, there must be somebody there who's going to be able to respond to a diabetes related emergency, whether that's to administer insulin injectably or whether it's to administer glucagon. So the decision to have a PDA, it's not a mandatory position. It is based on the student's needs and it's based on the parent's wishes. Sometimes and what the PDA can actually do is based on what the parent approves them to do. So, you know, usually that's basic care of the student in regards to those types of tasks, whether it's injecting insulin or injecting glucagon. The parent has to approve those things in order to do it. Okay.
Kathy, there are a few other comments or questions in the chat, but in the interest of time, would you like me to get these copied so that way we can send out maybe an email with
Please.
the answers? Okay.
Yes, please. Thank you very much.
Mhm.
Okay. EpiPen delays. There could be, we're hearing rumors that there might be delays in obtaining epinephrine pens for the 24-25 school year. So this is just a heads up to not discard any outdated doses, because in the past we have gotten extensions on those doses. And so don't throw them away. We're waiting to see what happens. We haven't heard any more about it other than rumors at this point. So just a heads up, don't throw things out yet for your expired epi. Support roles for 24-25. We've got best school nurse mentors. I'm hoping they all continue. Thank you so much to our best school nurse mentors this year. We really appreciate all of your work on behalf of this program. And so that program is going to continue for 24-25 with new assignments for our best mentors. And then we're also looking at migrant education nurse case manager positions. And we're looking at 2 of those that could serve our region, some of our districts in our region, and provide some additional support for students that way. Okay, these are kind of in chronological order, so I'm not going to spend a lot of time on them, but I'm going to go through them pretty quickly. So just so you know, Power of Providers, this is a ongoing Department of Health program, and they offer regular training opportunities. This was their last one, called Unmasking Long COVID. It might be of interest to you. These sessions are recorded, and so there's a link here if you would like to watch it. Most of them are about 1 hour, and then the next ones coming up you can see are here. POP is really focused on immunizations and vaccines, and so most of their presentations that they offer are really related to those 2 things, and how to help providers of any licensure look at how they could help promote them. I get a lot of requests for youth mental first aid, and so I just wanted to let you know there's a course coming up April 30th. That's from 12 to 4. It does require 2 hours of prep time, though. So it's a 4-hour course that's virtual, but you have 2 hours of prep time in advance. And there's a registration link for that course. Excellent. I would encourage you, if you've never done it, to think about going through that course this year or next year. Fentanyl Facts and First Aid Virtual Training. This course is done by Western Region Counter Drug Training Center, and we have one more course on the schedule, and that's coming up April 30th. So if you have folks who need or want additional information on fentanyl, this is an excellent course. And again, there's no charge for this one. If you're interested in providing OSPI input with the opioid overdose policy and how we're managing that in the schools, you know, with the new laws, there's going to be revisions to the policy and procedure that will be coming out from WASDA. And so this is our opportunity to provide input on that, and that's scheduled on Wednesday, May 1st from 3 to 4:30. And that's via WebEx. So you're going to want to register for it in advance and make sure that you have WebEx available for you on your system. And you'll have access to these PowerPoint slides, so you don't need to write all these things down. School Nurse Day. So please mark your calendars for May the 8th. You're going to have a link in PD Enroller. We're going to focus on Stop the Bleed, train. It's really going to be more of a train the trainer program. And so we want to make sure you feel comfortable, whether you use Stop the Bleed or you use another trauma intervention response training in your school districts. I'm sure you'll be involved with this in the coming years, and this is an opportunity for a lot of hands-on practice in the classroom. We're also going to be doing some peer sharing and problem solving. So we hope everybody can come. We are going to ask that you register in advance because of lunches. We want to make sure we have food for everyone and that we have materials for everyone. And that's going to be the morning session and the lunch, and the afternoon is going to be an OSPI session where we're going to be focusing on billing practices with Washington Healthcare Authority. So that will be from 1 to 4. And if you need to clock hours for that, you're going to want to register for it separately in advance. So there's a link here so you can register for the 1 to 4 session. And then one of the last things is the School Nurse Connects. So School Nurse Connects is our connection with the Department of Health. And this has been an ongoing program since COVID, where we get a chance to get together and talk about issues. And this particular one is going to focus on infection control guides for schools. So it's about time for the new manual to come out. And this is an opportunity for us to share input on infectious disease management in the school setting. So that's going to be Thursday, May 30th. Again, 3 to 4 p.m. has been the standing meeting time. I anticipate it will be 3 to 4 again for this particular month. And the link to register for that is pending. So we'll get that out to you as soon as we receive it. Our next school nurse mentor course is going to be June the 10th. That's a full day course, and it is open to any school nurse who is interested in developing their mentoring skills, in how they work with other school nurses with less experience than themselves, and how to help them grow in their professional role. It is based on BEST. It is part for those people who are going to serve as BEST school nurse mentors for that OSPI program. This is the 3rd session that they complete. So they do 2 sessions, 2 full days with a general course that's put on by OSPI BEST. And this 3rd session is their conclusion to their school nurse mentoring preparation. But this 3rd session is open to anybody who would like to come. It is not, you don't have to have completed the other 2 to attend this. That's only for people who are going to serve as BEST mentors. So that's free, and it is going to be a virtual course. And that's it for my update for this morning. So I'm going to log off, and I'm going to look at all the questions that people have submitted, and we're going to get answers back to everybody so we can share information. All right.
Thank you, Kathy.
So much. I'm going to stop sharing.
All right. Well, thank you. All right. So like Kathy said, we will make sure we get those questions out to you, and we'll just send them out to everyone, because the more info available to you, the better. All right. I see that we have Liz on here, and I know that she's busy this morning, as are you all, I'm sure, but I want to make sure that she has plenty of time to share her wisdom with us about doing health emergency drills in the school setting. So Liz, if you want to unmute, I have the websites pulled up, and if you need me to, I can share my screen for you. So just let me know.
Okay, perfect. Sorry for joining a little late this morning. We had a manifestation meeting that went a little longer than planned. So my name is Liz Prey. I am a school nurse in the Moses Lake School District, and am also the Washington State NASM director. So I was asked to come and talk to everybody today about going through and running what we would consider health or safety drills in the schools. This last school year is actually the first year I have not done one in probably 9 years. And so normally the date that we choose to do the drills in the buildings that I have is February 14th. And we always work together to make that the monthly drill for the building. And so when we talk about doing drills like that, it's actually a cardiac emergency preparedness drill. And so they're actually really cool to run. And so I don't know if anybody has AED programs within, I'm sure several districts do have them. But as you all know, being in the school setting and the only medical professional pretty much in your building or, you know, in some of our rural areas, remotely close to where you're at. You know, a lot of you probably have volunteer services that are volunteer firefighters that provide your ambulance services and things like that. And so it's always good to practice things and schedule things with your team, you know, just so you can debrief and kind of keep your skills up to date. And so the ones that we choose to do actually look at a situation that would require the AED to be pulled. And last year we actually ran a mega code with the fire department. Actually, the last 2 years we had a mega code scheduled with the fire department. And what I mean by that is we worked together with Project Adam Northwest. And if you haven't already teamed up with Project Adam Northwest, Ryan Schaefer is your contact person over there. So we teamed up with them because if there's a pediatric cardiac emergency, the closest person or the closest place for Moses Lake is Spokane, and that's Dr. Anderson is who they go see. And so Ryan Schaefer is the nurse that works with Dr. Anderson, and he's our contact person for all things AEDs and Project Adam. And he actually will come to the school and be or not be a part of, but just observe whatever you have going on and provide feedback to your team. The other person that you want to include is the person that works with the fire department and provides the education. And so for Moses Lake, that is Todd Chauncey. And so he normally will set that up with the fire department. And then, of course, you want to include your administrator or whoever does the safety within your buildings. And so when we scheduled the last couple of years up at the Moses Lake High School, that was Clint Scriven. And the one thing that you've got to know is the more that you can open that up to other people coming and watching what you're doing, that only provides feedback. And so we oh my gosh, what's his name, Lena, in the ESD up there, he does all the threat stuff.
Mike Dingle.
Yes, Mike is a very good person to reach out and let know that you're going to do one of these, because he comes in and looks at things like, okay, did you have a clear path for the fire department to come in? And did you have the person that went out and met them? And what does your system look like? Whereas Ryan Schaefer is the one that looks, okay, did the AED get pulled? Was the staff doing CPR correctly? Did somebody call 911? He looks at that. Mike looks at other things. And then as the nurse, you can choose to participate in the drill, or you can choose to monitor the drill. And we've actually opened it up to student involvement. So when we were up at the high school, we had a big conversation about, okay, when we go and we do this drill, are students in the building or are students not in the building? And that's going to depend on the conversation that you have with your administrator. We chose to do both of those drills at the high school with students in the building. And it was at different times of the day. And so we were testing the systems per se. One of them was closer to when we were going to go to lunch. And so we were looking at, okay, where's our bottleneck at? How are we looking at crowd control? Because I don't know if anybody's familiar, the high school is about 2,000 students. And so it was the perfect storm up there in both situations. And so we did not limit student response, because in that situation, you have students that have more training than the staff do, because up at the Moses Lake High School, you've got certified lifeguards on staff. Your Boy Scouts, any Boy Scouts that are local and have been through that first aid CPR training, or any of those survivor things. So those are all key things to look at. And so if students opted to respond to the situation, we debriefed with them as a team also, and opted not to limit their participation, because I mean, you want the people showing up to a situation that have the training to support what's going on. And so working with the fire department, both times we opted to do a mega code. And so when that student or victim went down, what happened was we were testing response times. We were looking for bottlenecks, and we were also making sure that the fire department had their opportunity to practice their systems. And so they actually came in, and we borrowed their mannequin so they could start an IV. They could make sure to hook up all their machines. They did everything that they needed to do to take that student out. And I'll tell you, we didn't prep the community for the first mega code. We prepped the students in the area, but we didn't prep the community. And one of the parents, who was also a first responder for the county, called me with the first one that we did, and asked if I was okay. And I was like, well, what do you mean, am I okay? And he goes, all of a sudden we got all these tones coming across that there was something going on at the high school, and this person was down, CPR was in progress, and then all of a sudden everything stopped. And nothing was discussed after that. And normally what happens when things stop, we wait for the coroner to get paged. And so you never want to see that happen in the school setting. And so the second time we ran that drill, we did a lot more prep and made sure that parents were aware that, okay, we will be having this go on. Please note that it is just a drill. We'll debrief with your students if they show up. So the first one that we did, and mind you, I've done them in the elementary schools, but I think it's more important to talk about it at the high school level, just because of the way that we morphed what we were doing. The first one was out in our gyms, and the PE class actually participated if they wanted to, but we also had an alternative location for them to go if they didn't. The following year, it was in the shop class, and we practiced skills that we learned with stop the bleed, tourniquet use, all of that stuff. And a drill is whatever you make it. And the important thing to remember is the fidelity. When you run those drills and you debrief as a team and you make those changes, you're able to actually fill out the forms and get certified as a heart safe school. And so I shared that link with Lena, along with the link to Project Adam, because they're a really good team to work with.
Would you like me to share my screen so that people can see that website?
Sure.
I'll send out the link as well soon. So
yeah. So, but you learn a lot of things about your team, and you learn just kind of different trainings that you need to do, and just things to make your team better. So, and those are all things that you want to learn before getting into an actual emergency. The important thing to remember though is as a team, you need to debrief after a situation like that, even if it is a drill, because you want to know, okay, what went right, what went wrong, and what do we have to change? So things that you've got to think about is not only the group of people that you include in on the trainings, but you've got to think of your systems. Okay, how are we going to communicate? What are we going to say over the radio? What's the easiest route to get to wherever we're at? And if anybody is interested in running one of these drills and you just need to go through and troubleshoot some things, I mean, reach out. I have no problem helping walk through any of that stuff with people.
That's awesome. Thank you. Did anyone have any questions or comments for Liz, or want to see that email, or sorry, the link again? We'll make sure it gets out in the email. We already
Oh, Mike
need to
is
send.
retiring this month?
He is.
Ugh,
I know. I know.
that really bums me out.
Did you see that quick comment from Penny?
Yes. So
Okay.
Penny, when you click on the link to the Heart Safe School certification, it actually will take you through everything that you need to go through that certification. And the team members that we involved included the community organizations that could potentially be responding to an event, like the Moses Lake Fire Department. Appropriate for sixth graders to learn bleeding control? Of course.
Yeah.
We teach fourth graders hands-only CPR. So, I mean, no one is going to fault you for providing education, you know, and preparing for a situation, because if you think about it, what happens if those same sixth graders come across a situation during the summertime? You know, they can say, my school nurse prepared me for this situation. I know what to do and I know not to panic. And so it's always a good thing to run through with your students, if nothing more than what to expect when you call 911 and how to not panic, and where are my landmarks, and how do I tell them where I'm at, what do I do if nobody's with me. Yeah, no one's going to fault you for teaching additional things. And I know that we don't have a set curriculum as to what any of us go out and teach in the classrooms, except for HIV. So nobody's going to fault you for that. And it just gets you more visible in with the community and out with your students. And if nothing more, it opens up a conversation between your student and their adult at home, and letting them know, hey, guess what I learned today? And whatever education that you provide to those students, make sure that you also include some kind of follow-up that goes home to those adults saying, hey, this is what we learned. If you want to learn some more about that, don't be afraid to reach out to me, or go to these websites, you know, and that just gets you more visible in the community.
Fantastic. I agree, Liz. The more education that we can provide, especially for in those younger students, if it's in a manner that they can understand, whether it's like their birth language of Spanish, or even just with simple plain language, the better. Yeah.
Well, and our ultimate goal as school nurses is prevention, because I mean, we've all been focusing on damage control even way before the pandemic. And, you know, we need to get towards that prevention piece and that public health piece, and where we're thinking about not only like our classroom community, but our school building community and the community that we live in general.
Yeah. I remember on my suicide prevention training that I took last time, they were talking about CPR for some reason, and they the guy mentioned that Seattle is probably one of the safest places to have a heart attack because everybody knows CPR. I didn't realize that, but thought that was pretty interesting. We have a raised hand here. Michelle, do you want to chime in here?
Going along with this, Liz, another great, I love your comment about prevention. And we had come to Chelan and we had students from Manson go out there. It's called Nick of Time, and you can look it up, NICK of Time. And it's named after a young man from Bellevue named Nick, who his aunt ended up starting this. And it's a health screening program that we have all our athletes who go through, you know, their standard physicals and stuff. But this is a deeper level situation where they bring in, they've got a pediatric cardiologist there, they run EKGs on the athletes or anybody who wants it done, an echocardiogram if needed, and make referrals from there. They did it in Chelan last June. It's quite a thing. You've got to have a lot of manpower to help make it happen. And students from like the health club and stuff like that at Chelan helped run it. But we actually had the athletic director's son, and I can share who it is because it's been in the newspaper and stuff up here. He was found to have, he's a 3-sport athlete, has gone through all his physicals, passed everything. He had Winky-Bach and ended up having to have a procedure done at Children's over the summer, and he's all back to playing and everything. But it was something that he kind of pushed back from Dad, going, I don't think I want to do this. And Dad said, no, let's do this. And then he was one of the ones, but there were several kids that were found with little things. And it's an awesome service that, and they'll, like, I think of Moses Lake because you've got a big facility and a lot of people there that it's easy to bring in. We just bust our kids from Manson to Chelan for it because it's a pretty big deal. It's an all-day thing, but it's amazing as we start looking at prevention. And kids have issues with their hearts that they don't know about that a standard sports physical doesn't catch.
Mhm. Well, and you bring up a good point too, Michelle, and having to bus your kids there. Even though Moses Lake is a big area and we have resources, we don't have the resources to put on something like that. You know, those providers would have to come in from another area. And so
Oh, they do. They bring
yeah.
everybody. All it really needs is like circulation of people, like students to help direct traffic is the only part we had to do. They bring in all the staff, and then the local EMS helped and did like blood pressures and that kind of stuff.
That's awesome. Yeah,
That's really awesome.
we have to get to the point where we are out of damage control and putting out fires and focusing more on prevention. And I know that's hard to do in, you know, as we're getting into that post-pandemic setting, because I mean, it's going to be a while before we're out of damage control, but I mean, we got to make sure that our teams are ready to handle an emergency. And so, yeah.
That's amazing stuff. Michelle, do you want to send me a link to the information for that? And I will put it in the mass email that we're going to be sending out to everybody. Fantastic. Okay. Any other comments or questions for Liz?
One thing to remember is it does not have to be a drill that tests your response time with AEDs, or, I mean, it could be any type of drill, because I mean, we all know that our staff, they're not medical providers, you know, and so if you're coming from a clinic or a hospital setting where you're used to being around medical providers, and it's hard to put yourself in that mindset that, oh my gosh, I don't have staff with the same type of training that I do, you know. And when you say, hey, open up this pocket and get this, well, they don't know what you're talking about, you know, where it just pops out of your mouth, you know, yeah, I need this. And you turn around and next thing you know, the contents of the bag are laid all over the place. So, I mean, don't be afraid to practice with your team. And I mean, don't limit yourself to what you're practicing either. If it's a traumatic injury where you're looking at tourniquet use and stop the bleed, practice it.
Yeah. Awesome. Thank you so much, Liz. I really appreciate your time this morning. That's such an awesome opportunity and fabulous, fabulous. Um,
I am gonna
if that,
pop off.
okay,
So, okay,
all right,
sorry to
thank you
kind
so
of jump
much.
in and run, but
We're so glad we could have you. Thank you.
thanks.
Okay, so we do have a couple of people here that I want to give them an opportunity to introduce. Well, Garth, you already have met on Zoom, but he has some people he would like to introduce, and then we also have Michelle, and I don't know how to say your last name, Michelle. Sorry. So as soon as Garth is done, we'll give Michelle a minute or two to introduce herself as well, and then turn the time over to Dr. Wallace. Okay, Garth, you're on mute. Oh man, no, we can't hear you. Do you want to try cycling your computer, and then in the meantime, we'll let Michelle introduce herself? Okay, well, we'll have you send out an email. All right,
All right,
we'll
can you
let you
hear me?
this time.
Can
Yeah,
you guys hear me?
yeah,
Oh,
thanks,
okay,
Michelle.
good. Okay. Well, yeah, he's having some difficulties with that. But hello, everybody. My name is Michelle Arcega. I am the new health educator here at the Chelan Douglas Health District. So this is my third week here so far. My background is in public health with a specialization in population health. And I just wanted to say that I'm very excited to collaborate with you all on promoting health and wellness among your student population. And I think it was really great to see how passionate and knowledgeable you all are about your students' needs and all the training that you're doing. I think that's amazing. But I'm excited to work with you all in the future.
Awesome. So, Michelle, what are some things that the nurses can reach out to you for?
Well, right now I'm still learning the role, so I'm trying to figure out what are some of the health issues you're seeing. So I'm seeing the diabetes as a issue that I saw, and I'm actually going out with our dietitian today to one of the schools in the Wenatchee School District. I'm not sure which one, but we're going to be doing a little workshop for My Plate education for nutrition. But yeah, if you guys have any ideas for any, future trainings or needs, you could reach out to me for sure. I don't have an exact like I'm not just mental health or nutrition. I'm kind of just trying to figure out what the needs are so that we can, implement some new programs or trainings for education.
Awesome. Well, thank you.
Yeah, thank you all.
All right. I am not seeing Dr. Wallace quite yet. He's probably running a little, running away with some meetings going on. So I'm not sure. Uh, I'm not sure if we want to introduce Amanda to do hers yet, because I know we wanted to wait until after Dr. Wallace has an opportunity to give our regional update. It's
Why don't we give
particularly
her,
since
it's
yours
only
is.
9:58. Let's give him a couple
Oh, is
minutes.
it? Oh, I'm
Yeah,
sorry. I wasn't even paying attention to the time. I'm sorry.
that's okay.
Okay. So, um, so in the interest of um, asking questions and being present with your students, one thing that we're going to do, Kathy introduced it briefly in her slides. So on May 8th, we're going to do the Stop the Bleed training and train the trainer. Because I don't know if any of you have had the opportunity to do that or do that, go through the training or train someone else, but we wanted to give you an opportunity to practice doing that. But the other thing we're going to be doing is an innovation relay. So it is truly problem solving and questioning of how we go about doing things. And I don't know if anyone's done an innovation relay before. They've had them at NASN and they're really quite fun. So one thing that I want to hear from you on, and I don't have it set up as a polling question, so I can't ask you. So I'll just have you put it in the chat if you don't mind. What are some issues with students that are frustrating you? Is it having staff give medications? Is it delegation methods? Is it frequent friends coming to the health room? What are some issues that are um, causing some difficulty for you in your practice right now? Just maybe some suggestions for things that we can work on in the innovation relay. So if you are interested in looking that up, there are some articles you can Google on innovation relay that have been done in at NASN. The one that I was involved in, they discussed mental health and the school nurse creating a tool that the school nurse within our scope of practice that we can use in helping students to discuss their feelings. And it was a very broad subject, and all of the innovations that our teams came up with was really quite interesting. So it was pretty fun. And I'm not doing it justice, but it was really fun. Okay, so thank you for your frequent friends. Okay, I'm used to handing out mileage. Thank you for the giggle this morning, Michelle. I appreciate it. Okay. Struggling with coordinating treatments or plans of care. Okay, these are all fantastic, and I thank you so much for sharing. Please keep them coming. I'll keep you updated with our innovation relay that we will have on May 8th. So I hope you all get registered and can come. And Dr. Wallace is with us. Thank you so much for sharing your time with us. We appreciate you every time for everything. So we'll turn the time over to you.
Thanks, Lene. Thanks so much. Good to see everybody. Happy spring. Welcome back from spring break. Hope everyone had a good trip or good time off. I'm going to share my screen, and really, I just wanted to run through pertussis because I'm getting so many questions about it. And I know that Amanda is with us and to talk about their experience. I unfortunately have to jump to another call at 10:30. So I thought I might try and go quickly and then either take questions or let Amanda present and try and get as much out of both of us while I'm here as possible. So I think as we've discussed, as people are aware, we're seeing a lot of pertussis cases. Are you able to see my screen?
Dr. Wallace,
Yep.
I'm not sure if there's something that might be rubbing on your microphone, but we're getting a lot of static.
Oh, interesting. Still?
So yeah, and it's kind of hard to hear you. Sorry, everybody.
You think maybe his battery is going down?
I'm not sure. Okay.
Still scratch.
No scratching.
Scratchy, or is that better?
Yay!
That's
Thank
better.
you. Yes.
That's weird. I was just on another call and nobody said I was weird, but maybe they were just hiding it.
Too polite.
Maybe my last meeting was worthless. Who knows? Thanks. Thank you for correcting that. So pertussis has been really interesting. So the illness usually runs through a classic progression of symptoms. So initially for 2 weeks, mild upper respiratory symptoms, then into these fits of severe coughing, post-tussive emesis, and the classic whooping for 6 weeks, and then that gradually goes away, but can take up to 2 months. And so is certainly an illness we want to prevent. But then the complications, especially in infants, apnea, pneumonia, seizures, and even death. Hospitalization seen in 50% oftentimes, and we know from history going back into the 1950s when there were vaccines into the era of childhood vaccines that severity as well as transmission is prevented by vaccines. Transmissions by respiratory droplets, it's not airborne, but it's on the larger droplets that are impeded by masks and distancing and good respiratory hygiene. The attack rate, that's the rate at which one person exposes others or infects others, or how likely you are to get it if you are in close proximity to another person, ranges from 25 to 80%, depends on immunity, but also on other precautions that are taken. It is a long disease. So the incubation period, the time it takes from one person to be exposed and contract it to the time that their symptoms show up and then that they can be contagious, is 21 days. And then that duration of contagiousness can last 21 days or longer after their coughing episodes develop. So really slow moving illness as far as how quickly it moves through a population because of those prolonged incubation periods and duration of contagiousness. We have classifications of diagnosis. So confirmed are those that have a positive test and the cough illness. Probable cases are those that aren't testing positive or were not tested, but have the classic cough illness with a known link to another case. And then we have a lot of suspected cases, but those are ones that are PCR negative. They might have the cough, but they don't have an epi-link, or they have an epi-link without the classic symptoms, or without any symptoms. So those suspect cases are not ones that we report, but they're ones that you can consider those maybe, maybe not. We don't have enough information to confirm with certainty that those are truly pertussis. Antibiotic treatment, azithromycin or Bactrim, works well for both treatment and prophylaxis. And then certainly isolation and droplet precautions, which include masking, are effective in healthcare settings and other settings when there is a risk of transmission. On a state level, we've seen pertussis come and go. Certainly a huge decline with initial vaccines. There's been an increase since the acellular pertussis vaccine was introduced. So the whole cell pertussis is what, those of us who are vaccinated in the 1970s, 1980s, early 1990s received that whole cell. That was more effective as far as inducing immunity, but carried with it side effects, really high fevers, sometimes febrile seizures. And so the introduction of the acellular pertussis vaccine in the 1990s offered a vaccine with less side effects, but also didn't get as deep or as long of an immune response. And so it's not uncommon to see immunity wane from the acellular pertussis. And I'll talk a little bit more about that, but I think that explains some of what we're seeing. We see cycles. 2012 was a big year in Washington, 5,000 cases, another big year in 2015. In Chelan Douglas, usually less than 6 cases a year. So certainly the numbers that we've seen have been much higher than we usually see. These are this map is of the health districts or counties that reported pertussis in the past year. And over 2022, 2023, the numbers were low, but you can see in the red in that bottom graph, numbers started coming up statewide at the end of 2023. This is an epi curve from our cases now in Chelan Douglas up through April 16th. So we were notified of that first case on February 2nd. That individual was symptomatic on December 31st and potentially contagious for quite a while before diagnosis. We had the first lab confirmed case later in February, a second school involved at the end of February, then started getting cases and schools involved that were not linked to any other known cases, which led us to understand that it was much more broadly spread throughout the community. To date, 8 schools have been involved, and we have 72 total cases. A number of cases also exist throughout the community that are not individuals that are enrolled in schools. These are epi curves broken down by school, and so you can see as there's a little bit of a pattern of progression, a couple early cases, a lot of cases, and then a little bit of a tail that we see naturally occurring in the first, second, even third school that's been involved, and then a number of schools that have a very low number of cases. These charts break down school age distribution and vaccination status. So a couple of schools have seen more cases than others. We're seeing more cases in the junior high and high school age group than elementary school, and fortunately only have 2 infants that have been involved to date. Not surprising, more of the cases are among vaccinated individuals than unvaccinated. That's because we've got a large number of people in our population that have received vaccines. Immunity does wane. Immunity due to vaccines is partial. And when you have a lot of people in the community that are vaccinated, as an illness rolls through, there are more people for the illness to impact, and so it's not a surprise that we've got a lot of vaccinated people that are still getting pertussis, just like we have a lot of people with COVID or influenza that still get sick from those illnesses. The things we've learned thus far, kind of take-home points. Our numbers were increasing prior to spring break. That was fantastic. I think we still have another week or 2 before we determine what the impact of spring break was on our cases. Is it going to make things worse because people were traveling, or is it going to make things better because it provided a lull in the action? I've tried to make it clear, and I certainly think it's true, that pertussis is being detected by schools by the work that you guys are all doing, and recognizing that they're kids that are sick, advising that they get tested and treated as appropriate. And so we're initially being alerted oftentimes by schools that they're kids that are sick, and then that kids have pertussis. I think transmission is going on maybe even less in school than it is in community settings. A lot of the case investigation is linking cases to sleepovers rather than in-school activities. We haven't been able to identify any school clubs or sports or specific places where there's been more transmission than anywhere else. But I think consistently we've seen long durations of time inside in close proximity, and that's occurring just as much at home or outside of school as it is in school. We're seeing a lot of cases that don't have links to any other cases, and so that tells us that there's much more spread out there, much more illness out there than we've been able to detect. And then we're seeing a vaccine impact and effect, I think, because of the age distribution. So as I showed you earlier, there are more middle school and high schoolers, and that could be a function of just the that it's being identified in schools, but really, if you look at it, I think we're seeing that success of the vaccine wanes 3, 4, 5 years after final booster dose. So childhood vaccine schedule is 2, 4, 6, 18 months, and then 11 to 12 years. And so either kids are not getting their 11 to 12-year-old booster dose, or 2, 3, 4 years after that 11 or 12-year-old booster dose, vaccine uh, uh, effectiveness is starting to wane, and that's something we know exists. But it tells me also that younger age groups are being protected. Illness severity doesn't always follow that classic progression of pertussis. Oftentimes, it's just a mild upper respiratory infection. A lot of times, the cough is not severe. We haven't seen hospitalizations yet, so I do think illness severity is being attenuated by the vaccine. And then again, as I said, case presentation, we're not seeing those classic symptoms. We're working hard to prevent severe cases, prevent cases, especially in infants, and doing what we can to reduce rates of transmission. That means making detection as easy and as accessible as possible, and making it clear when and who should be excluded, and ensuring people get treatment for the illness, as well as prophylaxis or preventive treatment for household contacts and high-risk contacts. The vaccine is certainly working, and we want to continue to promote and support access to vaccination. I've met a lot with healthcare and what public health is doing. Chelan Douglas Health District is trying to access open doors to access for testing and treatment, making sure that our laboratories have throughput and can get as many swabs as needed be passed through either of the labs or any of the labs that our healthcare partners are using. Making sure that the appropriate people are treated either for illness or for preventive reasons, and then ensure that advice on isolation is consistent across the boards. And vaccination is made available and encouraged to protect those key populations. You guys are doing a fantastic job. Communications that I've seen to students and staff, as well as to families, has been really strong. I think things would be a lot worse if there were more sick kids staying in school. So excluding, especially when there's a known illness circulating around school, is really important. The work that you guys have done to assist in case investigation, contact tracing, just is amazing. I mean, you know your students better than we know the general public, and oftentimes have intimate understanding of the connections between individuals and families. I think I saw it described that one case was soon to be girlfriend of another case. And I think that explains the depth of investigation and how intimately you guys know the lives of your students, and really appreciate that. You've been able to identify epi-links where our contact tracers were unable to do. And then we've been able to share your experiences and try and encourage healthcare and other partners to make things smoother and facilitate better communication. So I certainly want to get input from you guys in this forum there. I talked a little bit about our roles, and so really for you guys, I'd love to hear lessons learned. I'd love to hear how messaging is going, what communication methods, tools, or specific messages could improve the work that you guys do, and then any and all tips to improve collaboration between schools and healthcare. So I'll stop there. I can take questions, or if we guys want to move on to Amanda and her presentation, I'm happy to do that as well. And I can switch. I can see the chat now.
Dr. Wallace, could you
Yes.
to sensitivity of testing and how
Mhm.
that can be helpful, but not, a final word?
Yeah, absolutely. So thank you for that question. Testing is horribly inaccurate in pertussis. The pertussis swab is a nasopharyngeal swab. You guys can think back to early in COVID about the swab that felt like it was tickling or putting a hole in your brain. That's the pertussis swab. So it's really deep, and there's a lot of resistance to that and a lot of hesitation to go really as deep as need be. And then in various phases of the illness, the body's producing more, or the virus is in higher numbers than other phases. So by the time you get to the really severe coughing, oftentimes the virus is on its way out, has already done the damage, and it's actually the toxin and the damage the toxin does to the body that results in the paroxysmal coughing and the long effects. And so it's less that the test is not very accurate, but because of the timing and because of the need for a really good sample, oftentimes somebody can have pertussis and test negative. And so for that reason, we've worked a lot with healthcare partners. I've made calls to physicians and other providers to say, hey, listen, if you are suspecting pertussis in this setting where we have a lot of cases, go ahead and treat, because azithromycin is essentially a harmless medication compared to the risk that the patient might face if they truly did have pertussis and could pass it on to others. Um, so yeah, Amanda, thanks for that.
Any other questions for Dr. Wallace or other comments on the pertussis or other health concerns that are trending? Nope. Okay, well, if you do, please put them in the chat and we'll get you answers. All right. Thank you so much for your time, Dr. Wallace. We're glad we could have you join us. And um, Amanda, if you're okay, we'll just go ahead and let you jump into your presentation as well. And that way Dr. Wallace can still be here for some of that too.
Yes, thank you. I am Amanda Peasley, and I am the school nurse at Pinnacles Prep. And I'm flattered to be here to talk to you today about pertussis. A couple months ago, I would have never imagined I would be doing this, but here we are. Some of my presentation will be a repeat of what Dr. Wallace has said, so I will try and make it more specific to us as school nurses. And I'll keep an eye on the time here. Let's see. So I'm not a new nurse, but I am new to school nursing. I just finished my first year as a school nurse, and I am also pursuing my master's in public health. And so all of these things have come together, including a pertussis outbreak that started at my school, and to be here and kind of do a little bit of presenting towards my end of my program here. I do like to talk about Pinnacles really quick, just because we are the very first charter school in the whole ESD region. We're a free public school, and right now we have grades 6 through 9, and we're growing each year, so that eventually will be through high school. And we have kiddos from all around. We have Wenatchee, East Wenatchee, Kashmir, I think Leavenworth, and even all the way to Quincy. And so this was particularly challenging as we were doing contact tracing with kids during pertussis. So I have 4 kind of main topics today. I'll go through the overview quite quickly, but some of the things are really important. So I want to start out with a poll question, and I think Sheila is going to help with this. So basically, I was just curious who on the call today has had any cases in their school. like Dr. Wallace said, we have 9 or 8 schools currently with cases. And this is anonymous. And then just let me know when I should move on.
Amanda, can you see the poll question that's up on the screen?
Not right now.
Oh, okay.
I answered my poll question.
Okay.
Well, now did I?
Okay. Well, we have about 71% of our participants on the call have answered
Okay,
the poll question.
perfect.
So if that's all right with you, I'll go ahead and end the poll and we can
Okay.
see the answers. Okay. So sharing the results, you should hopefully, well, I don't know if you can see because you're in presenting mode, but we have 61% said no, they haven't had any lab confirmed or presumed positive cases. We have about 32% said 1 to 4 cases, and then just 2 people or 6% said yes to 10 plus cases.
Okay, great. So if you haven't seen it yet, it is in the community, and we'll talk about what to watch for and how to respond. This slide, the main thing that I really like to highlight in this slide is this yellow section, the first 2 weeks. This is what is so challenging about pertussis is it's very mild at the beginning. These kids might not even have a fever. They might have a mild cough, runny nose, common cold types of things. Things we would not normally exclude kids from school or certainly not send them to the doctor looking for antibiotics. However, with pertussis actively circulating, if it's in your school especially, this is where as the school nurse, we really need to be watching out for these new symptoms and following up on these kids. As Dr. Wells mentioned, in our situation with our first case, we were way into about like week 5 to 6, and this kid was severely ill and had those kind of classic symptoms of the whooping cough and the vomiting, which was how he was finally diagnosed. The issue at that point was we had a whole month of exposure to other kids at school, and at that point was every single little cough I could hear, I was following up on, and quite challenging. I would say it slowed down for us. And so in talking with public health, Chelan Douglas Health District, leading up to this presentation, I thought, oh, wow, this is getting way better. Not necessarily for other schools. We are still seeing pretty high rates. And like Dr. Wallace said, it'll be a couple weeks still after spring break to see how that's going to affect. We are going to talk a lot about vaccination because it's just the #1 thing to do. This graphic is really helpful. You can see there's 5 doses of DTaP for young kids, and then 11 to 12-year-olds will get that first Tdap booster. Every single pregnancy, we get a vaccine, and then adults can get one every 10 years. And I think that's a really important thing to note is when you're working with families is just to remind parents and caregivers and also the staff at your school, if they're not up to date on that, to seek out updated booster shot for their Tdap. At our school, when we had our first case, it was at the end of a stretch of very high absenteeism for COVID, influenza, and other illnesses. And so we actually encouraged masking for basically the whole month of February into March. It was not required, but it was strongly encouraged. And I would say our staff was quite compliant with that. However, kids, we're middle school, 6th through 9th grade. So they were harder to convince, but I do think we were fairly successful with that. Okay, Dr. Wallace went through this. As far as kids being out of school, it is just for the 5 days of antibiotics, and then they can come back to school. So, ironically, by the time our first case came back to school, we were just getting started with finding out the other kids who were sick. Let's see. I love this slide. Dr. Wallace had this one. I think it was from the year before, though. So if you look at the blue, you can see at the end of 23, it was already starting, the cases were already starting to increase. And this is through the state of, the whole state of Washington. And then the red, if you go back to the beginning here, we're just climbing. And it's going to be interesting to watch. Here again is about the last 10 years. And if you look right at the end of 23, we're just starting to hit that epidemic threshold. And something exciting for me, at least as a school nurse and someone who loves public health, is here we are. Chelan and Douglas counties are just leading the way here. If you're part of that 60% who hasn't seen it in your school yet, I would be really vigilant about monitoring for symptoms. Okay, next poll question has to do with feeling prepared at your school for communicable disease outbreak.
Okay, I just posted it for you. The question is, I have the resources, knowledge, material, support I need to respond to a communicable disease outbreak at my school. Not at all, minimally, somewhat, mostly, or completely. So we'll give it a moment for people to be able to put their question or put their answers in.
I appreciate everyone's participation. I'm actually home today because I feel like I get about 30% of what happens at these meetings when I'm in my office.
All right, well, we have 70% that have participated so far. So I'm going to go ahead and end the poll and share out the results with everyone. So we have 0% that said not at all. So that's good that they feel like they have, most people feel like they have some support and knowledge and materials. So we have 4% that said minimally, 29% that said somewhat, 54% that said mostly, and 14% that said completely. We have had some input in the chat, but we can share that out. Would you like me to read that out to you really quick?
What's in the chat?
So yeah, we have Michelle said that she feels way more prepared after COVID. And Amber put in some feedback that Dr. Wallace has addressed as well. And then Erica at Lake Chelan said, it's funny that we as nurses are getting a lot of flack for sending kids home sick or asking for them to see a doctor to be tested. We are constantly told that the health department has gone over protocols with local doctors, but we are on the same page. But we could not be further apart with doctors. It is exhausting as the nurse to keep getting so much pushback, not only from parents, but from the local doctors. And Amanda, I think this is something that you discuss with your presentation today, the advocacy piece and the collaboration.
Yeah. Yes. It shows.
Oh, stop sharing. Sorry. There we go.
Sorry
about that. There we go. Yep.
I still have that on mine here. Let me see if I can get rid of this poll here. Okay. So this is the piece where I brought in the role for us as school nurses, and I'll go through each of these, but the collaboration and advocacy piece is something I saw come up in an email thread as far as feeling like there were mixed messages. So prevention, I'm going to skip right through. I wanted to put a really brief video here of what it sounds like when these kids have this severe cough. And my frustration tolerance did not allow me to get to that point. So if you have time later, take a listen. It's very distinct, really hard to hear kids struggling to breathe like that. So surveillance, like I said, I'm a new school nurse. And so at the end of January was my first time where I was starting to see greater than 10% absenteeism. And I hadn't collaborated with the health district at all, other than seeing, Dr. Wallace here on these meetings. And so, finding this form from them and being able to report our absences was how my week started. And I thought that was stressful. We were seeing COVID, flu, and GI circulating pretty wildly. I think we're up to about 13% absences just for illness, not other reasons that kids were out. Reporting, pertussis is a notifiable condition. And so this was another first for me, was needing to find this paper. I knew I had it, and make sure I went through the right process, which was just notifying our local health district, and then they from there go up to the state of Washington, and it actually gets notified to the CDC. So I will, if you don't have this form in your office for, reference, I would encourage you just to print it out and have it. This website with Washington State Department of Health is wonderful. It goes through every single notifiable disease and how to manage it in the community. Most of the cases that Dr. Wallace was talking about with pertussis were notified to them through school nurses. I love that anecdote of a soon-to-be girlfriend or something, because it is, we really know our kids like that, or who's cousins, or who, all of those connections that, just somebody on a phone doing contact tracing is not going to pick up on. Mitigation. So this was the end of January. We're seeing a lot of illness, and so I stepped up my game. Part of why I asked in that last poll question about preparation was I had lots of masks at school, but I did not have enough masks for, 200 for weeks on end. I had enough for a couple days, and I thought, oh, well, I will ask the ESD or the health district to kind of help bump up our mask supply, and neither of them had any to provide. And so a takeaway for me is par stock for our school to have several days worth of masks for kids. It came up several times. At what point do we just close the school? Some parents are going to be extremely worried. Maybe, we had a newborn sibling in our school community, and some, of course, think it's just a mild cough. It's no big deal. Natural immunity is the best way to get it. And so masking was something that we were fairly successful with. Opening windows, having ventilation, just encouraging those things. Again, you're the only health person probably in your whole school, if not multiple schools. And so things that might feel common or, just no-brainers to us need reminding to staff. And then I have this little Zoom on here. We were able to move a few events, like our weekly all-school assembly, onto Zoom for several weeks, and change a few other evening events virtual while we were at kind of the high point of our outbreak. Collaboration. So the connections I was able to make throughout this process have been a total silver lining in this experience. I invited Luke Davies before he steps down from his role to come to our school board meeting and present on what was going on. This was the third week in February, and so it was pretty new. We were very actively tracing kids and just wanting to know what the best practice was. So reach out to health districts. I think that was in my conversations. It's nice. I have faces for names and people to call. I asked if there was a specific person to reference, and because of the way these situations work, where there'll be years without any cases. So there is a whole team devoted to pertussis. And then when something like this happens, they will scale up. And so if you need to get a hold of somebody at the health district and you don't have your own contact already, just call the main number, let them know what you're looking for. There's lots of wonderful people you can work with. And then this is the advocacy piece, something I definitely agree with the other nurses who are saying they've felt a lot of pushback from providers. I experienced that especially early on because there will be years and years where we don't have cases here in our local community. It is not a common thing. Providers are told over and over not to prescribe antibiotics. However, in this situation, you sort of freely want to give people antibiotics. So if there's no other known illness, so if it's not flu, it's not COVID, it's not something easily identifiable, and they have a cough and they've been exposed or potentially been exposed, they should have antibiotics. So what I did is I printed, this is a letter from Chelan Douglas Health District to providers in the area. I would send this home with kids and highlight the circumstances that they were seeing, because when the health district does notifications, they're not calling every single provider in our area. They'll sort of, do a communication tree where it'll go to the directors, the infectious disease doctors, the administrators, and then, they pass it on to the other providers. So if it's private practice or somebody who maybe just hasn't read their email recently, they might not have this information. And so as my advocacy piece, I tried to bridge that gap, and I had really good results when people would show up. Really, you just said pinnacles and people were escorted to a private space and given antibiotics. So a few other resources. So I've talked a lot about health districts, and I know we're not all Chelan Douglas County. And so there's Grant County and Okanagan County on there. I believe Dr. Waltz is also the medical director for Okanagan County. Is that right? Yes. Okay. And then I believe we're going to be hosting some Grant County public health officials at a future monthly meeting, but I just think it is a really great opportunity to remind people to get to know who your people are. And, that's something we could look at as a part of these monthly meetings, is hosting people. It's been nice to see Garth. I've already reached out to him for some opioid training at school. And then Michelle, I'm excited to see how we can partner with Michelle to bring some education to our school too. Community medical services. We partner with Columbia Valley Community Health and have a monthly school-based health service with them. So because we already have that relationship, when they were coming February, March, I was able to request extra doses of Tdap. And some of our 6th graders who hadn't yet had their 11 and 12-year-old dose, and some of our staff who needed updates were able to get vaccinated at those events. And just making that easy for people and giving them that reminder and having them think, gosh, has it really been 10 years since my last dose? That was really helpful. It's just, a couple doses here and there, and it starts to really add up. And then from the state, there's some other great resources. The Caravan is a mobile health unit, and we have used them at our school twice this year, primarily for childhood vaccinations. but they also do blood sugar checks, blood pressure screenings, and you have to plan a bit in advance, but we had them at our back to school event in August. And then I did a flu and COVID kind of push in October. And that was a really great service. I would say I think it's a little bit easier to use CVCH just because they're local. However, then everybody's a patient of them. So keep that in mind if you have. So, for example, I think the powwow up at Pascal Sherman, this would be a wonderful resource to have. You could even look through your sixth graders and see who's going to need their TDAP before school starts in the fall and reach out to those families. Power of Providers, Kathy mentioned them earlier today, but they're another great advocacy and education group for any kind of healthcare providers in the state. It's mostly for COVID, but I feel like the training that I get about vaccines for COVID are very much, interchangeable with other vaccine education. And again, getting our staff their boosters and updates and healthcare is really helpful too, because when we have, these viruses or these infections going around, it's not just the kids, and we can't function without all of our staff too. So, okay. So I have one more poll question, and then that is it for me, unless anyone has other questions. So this is just about if you learned anything new today, any new resources, or how you can advocate.
Okay, so this presentation has enhanced my knowledge of pertussis, my role as a school nurse, and resources available in my community. Not at all, minimally, somewhat, mostly, or completely. So we'll give them a moment to input their answers. We've got about 57. Oh, it just jumped. Sorry, I was going to say 57%. But now we have 60%. Okay, so we'll
Perfect.
end the poll. Do you want me to send you that information or share it out, or what would you like me to do with that information for you?
I would love if you could send it to me. That would be great.
Okay, because this is feedback for you mostly, right? Okay. All right, awesome. Well, thank you so much.
Yeah, and
All
then
right.
I don't know if was there anything else in the chat.
Some comments about well, Amber posted that the cases at her school had dropped after spring break, so it was good timing to have the kids out for a week. So that was well, and the Dr. Wallace had responded to a comment about the resistance from healthcare providers on testing and treating students. He said, please know that if that has continued, or please let me know if that has continued. I've met with several healthcare groups since the last time we discussed. I've spoken with a lot of leadership that are recognizing and working on better ways to get messages to the front lines of their clinics. So I think that that in combination with how you shared with us how they disseminate the information really kind of says a lot about some of the resistance that we see, because we see it in schools before they might hear that message from the health department.
Yeah, okay. Excellent. I have some references here, and that is it. Thank you everyone for your time.
All right. Thank you so much. We really appreciate that. Thank you, Amanda. We thank you for your time. That was really great. You put a lot of work into that, and we really appreciate it. It looks like there's a new one in the chat. Oh, a thank you from Kathy. So we do have a few minutes left in our meeting. Kathy, would you be interested in answering some of those PDA questions that were brought up at the beginning of the meeting? We can still send out the answers to people, but I'm just wondering if you'd be interested in doing that now on the fly,
Yeah.
or okay.
Yes, I can't see them, so
Of
could you
course.
share
Well,
with
I can scroll back and pull those up for you.
Okay.
Just give me a moment. Okay.
Thank
where
you so
was-
much, Amanda. That was great.
Okay. So we had already asked the question about billing
Mhm.
in the doctor's office. Okay. So there was a comment, it is difficult to do to do this PDA training at the busiest time of year, not only for us nurses, but other staff are busy as well. We've been doing it mid-August, but I guess that won't be possible without current care plans, question mark. So I'm wondering if that means that they're wanting to know if we could do PDA training without the care plan. This is Amber's question or comment. Amber, did you want to expound on that for us, or?
Yeah, thank you. It's just, it feels like it's just one more hoop we have to jump through, and we kind of like have found a way to like get it done. We pay the staff a couple of hours that are willing to be PDAs and that we feel are would be capable of doing it. Because it's not everybody that's willing would be a good person to do it. And then it's like, well, you got to have the, and a lot of times it's like with the care plans, I might not get those till a day before school starts, 2 days before, and staff have the staff are like, they are lined out minute to minute in those days, and maybe not even working yet. Right. So, and don't necessarily want to go to Wenatchee on their last couple of days before they have to be back to work to do a training, and it just feels like a roadblock. And so, if care plans, what I've done in the past years was fax in care plans and before we leave in June, and or have them ready to be faxed in, have them scanned, the ones that we have, and then we've done it via Zoom, so that people, to make it, I don't know if I'd say more palatable, like just people seem less resistant to it if they can just do it from,
The privacy.
outside of, right. And it just feels like, it's like, gosh, I just can't imagine trying to carve out time, or once you've started that school year, go saying, okay, well, I know you just worked all day, but we're going to go do a training down at Confluence, or I need to find subs for you. And it's just a lot. And I know that we have to do it and it's important, but at the same time, it's already, I mean, I don't, finding subs and doing all the arranging, and then it's expensive because it comes out of my budget. So
Hey, well, that's a lot. That's a lot to to unload there. So yes, and there isn't really anything that I would disagree with in terms of it is time, it is money, it is expensive, it is. But on the other hand, I guess I would also weigh it against, well, it is safer. People who are trained, people tend to not remember what they hear and see in a class. And we know that. I mean, that's just the reality, is that people don't necessarily remember what they learned in PDA training 2-3 months later. It is very difficult for adults to retain information that they have learned, particularly if they never practice it and they don't have a chance to experience it, in real life. So that is one of the reasons why PDA training is required on an annual basis. And an annual basis is really not all that great, you know, because you're expecting someone to remember how to care for a student or what to do in the event of an emergency or how to manage a student from day to day. What you're providing them in August, you expect them to remember that, you know, come May, you know, so that's a lot of challenge. I know Confluence Health certainly does things remotely. They recognize that people's time is limited and they will do that. But if that's the choice, then there still needs to be a skill verification for people. Because again, if they're expected to do a skill, if that's the job of the PDA, is really going to be to administer medications to the student, for example, or doing whatever they're doing, a finger stick blood glucose, I don't know, whatever their task is that the parent has asked them to do, they really need to do it hands-on, and not practice on the student, for example. They really need to practice in advance and learn how to do it. You know, just like with a seizure PDA, this just requires extra training for staff to be able to provide these types of skills. So I recognize the challenges in doing it. You know, we have had lots of conversations, for example, with Seattle Children's in the past about the difficulties that schools have when the care plans are not showing up until like the day before school starts, because that's really not enough time for people to get things ready for those students. You know, some people have done their PDA training at different times of the school year. The problem is that if the PDA is expected to provide care to the student in the absence of the nurse, then they're really not going to be ready in September. Now, the benefit at your district, Amber, is that you're there every day. I mean, that is a benefit, because a lot of folks who are on the line are not. And so they're not at the building, and they're really not going to be available to help if that PDA needs something. And so it's some of these requirements are really put in place for that reason, for that PDA training, is because there are a lot of cases where that PDA is going to be the only one there. And we need to make sure that they have responded appropriately to the student, and done the best they could do, get the best training that they can, and feel comfortable and feel knowledgeable. So I don't know that answers your question, really. I mean, I recognize it. I do recognize that all of these things take a lot of work and they do take a lot of money. But at the same time, a bad outcome for a student can be really expensive. So if there were a lawsuit against the school, because so often one of the things we hear from people is, well, you know, I didn't do it right because I wasn't trained. And oftentimes that's used as the rationale for why something went wrong was, well, no one trained me correctly on how to do it. And then when we look back to see, well, was the person trained correctly, adequately? Is there documentation of that? That's one of the reasons when we do site visits, we're looking to see, how did you document people's training? Because that's what would need to be shown in a court of law. You'd have to show what had been taught, and that the person really did demonstrate that they were capable of performing skills for a student. So it's not answering your question. It really is just, I'm recognizing it. I know that's difficult, but it is, but PDA is, the requirement is, if a school wants to have people in the role, then they do need to ensure that they are getting trained on a regular basis.
Okay, thank you, both of you. Thanks for asking that question, because it is truly difficult to get all of the trainings and delegations in before school starts, and that's a tough time of year.
Yes, and I agree with the comment in here from Sarah, who says it's nerve-wracking to leave a diabetic student in the care of PDAs, even when you trust them. Some school nurses report, in nurses in general, if you haven't cared for a pediatric patient, you know, for many years, and you haven't cared for a pediatric person with type 1 diabetes, particularly if it's not well-controlled diabetes, that's pretty nerve-wracking. And so if you're not, and that's one of the reasons I often get in touch with people about their district assessment data and how they're rating their severity of their students. When you have a student who has a diagnosis like diabetes, or you have students who are seizing on a regular, you know, they're not well controlled on their treatment plan. Those are really life-threatening, literally are life-threatening health conditions. And regardless of how your district has staffed with an RN or PDAs or health room assistants, however you are staffed, it doesn't change the severity level of the student. You know, if the student requires the nurse to be available to them, then that is how they should be. That is how they should be categorized in terms of their severity.
Yeah, thank you. Okay, so there was another comment here from Sarah. Providence just told me this week that they have or are doing mostly in-person trainings now. However, they did allow me to schedule a Zoom training since we are so far away from them. They were willing to mail me some supplies for skills checkoffs, which was super helpful. So
Yeah.
Sarah, also just a quick plug in too, we have those diabetes training kits as well that you can use. So we have some supplies that you can check out from the ESD. Sorry, Kathy, go ahead.
Oh, no, that is true. That is how Providence does it. They mail the kits. And so what you end up with is a kit at your school. And again, see, this is why the nurse has to be available, because you've got to have the materials and be with the person so that you can help them with those hands-on skills, give them an opportunity to practice and make sure they can do that. But in those cases, you should get the supplies directly from Providence. They will send them to you. But as Lane is describing, we have diabetes kits. So I think we have 3 of them. And so you're welcome to just check those out. And they have all the supplies in them that you could want, and use whatever you feel or whatever is appropriate for that training event.
Fantastic. All right. Well, I think those were the 2 main questions that were left unanswered in the chat anyway. Do you have, does anyone have any other questions that I may have missed, or that you're wanting to ask before we end our meeting today? Oh, do you keep the kit? Oh, yeah. Sorry, Sheila, I just understood what you're trying to ask. So the PDA kit that is sent to you
Yeah, for Providence.
do
the
you get to
system-
keep that?
Yeah. And do you pay for it? Just curious, Sarah.
I have to mail it back.
Okay.
Okay. Well, just know that we have that available. We have resources available here that you can check out and to help with skills check off, or even just a refresh during the school year as well. So, all right. Well, there were some people that needed to leave the meeting that didn't get those answers, so we will still send out an email to everyone with those answers, as well as the website links from the Heart Safe schools that Liz Prey referred to earlier in our meeting as well. So thank you so much, everyone, for joining us today. It was a really great meeting, learning all of those things about the health safety drills, and from Dr. Wallace and Amanda and all of our regional updates. It's always so much information. So please feel free to watch it again. I'm going to share my screen really briefly. For those that are watching the Zoom recording, and you weren't able to attend the live meeting, this slide is for you to be able to get clock hours for the meeting. We'll also include it as a slide so you can click that link there. But please feel free to go back and find the recording of the meeting and watch it again if you want to revisit some of those issues or some of those questions and refresh your skills and knowledge. So thank you so much for being here, and we appreciate you all, and have a great rest of your day, everyone.